I believe everybody's on here that should be on here now. So like I told for you that weren't there, we're going to be covering majority of what's left of chapter 12 tonight, talking about diseases at the organ level and organ systems and organisms, infections, viruses, the toll they take on the body and how the body reacts to such things. If I was to say, diseases at the organ level, what are some things you guys think of just right off the bat?
Like kidney disease?
I'm going to stop sharing for 1 second while we keep talking. Kidney disease, okay. What else?
MODS,
Okay, what do you mean by that?
multiple organ dysfunction syndrome, I think.
Okay. Now, what else? There's tons of stuff. Name some other ones.
Cancer.
Okay, what specifically what to do with cancer? I mean, cancer can come in many forms as far as organs, right? But it can also affect different organ systems. Does anybody truly know what is happening when cancer is taking over maybe an organ or maybe a body system?
There's a bad mutation in the cell.
Okay, it's close to that, right? So when we talk about cancer is actually one of the unique things that it actually will spread and replicate itself. It's one of the only things it does. And when we start talking about cells and organisms and all that, we're going to really look at some of those functions that do that, right? That multiply, that replicate. And what's the problem when we talk about, especially a disease process replicating? What are some issues that we can see with that?
Begins taking the body's resources and diverting them.
Yeah, and that's a good way of saying it. It takes the body's resources and diverts them, right? So one of the bigger issues that we have with diseases isn't necessarily treating them, but might be how do we identify what started this? How do we identify this disease in itself? And really that really falls down to pathology and pathophys and looking at things at a different level, right? So when we talk about genetics and diseases and other processes, what role do genetics play in diseases? And when we talk about genetics, maybe it's non-genetic too, like environmental. So what role and what are some diseases you can think of where that might take a toll on the body, or some things that you think might be genetic or passed down through traits?
Parkinson's.
Okay, so cardiac issues, sure. What else? Here's the thing. When we think of infections, when we think of diseases, we have bacteria, we have fungi, parasites, all these different things. But you guys are able to see this PowerPoint, right? I just want to make sure.
Yes.
Okay. We have to look at how do we treat them and how did we find out about this disease? And, especially when we talk about infectious diseases, we've really done more research in the last couple years on infectious disease based off of what's going on in the world than we have in prior decades. But we also have to look at generic structures of a disease. When we talk about generic structures, we're talking about things that we inherit from our parents or from their parents' parents or, from down the line. So we get 23 chromosomes from both our mother and our father for a total of 46 chromosomes. That doesn't necessarily mean you inherit diseases, but you can, right? You might have cardiac issues on your father's side. You might have cardiac issues on your mother's side, whatever it might be. Many disease processes are actually due to both environmental and lifestyle factors. So what are some things we think of if I say environmental factors?
Carcinogens.
Okay, carcinogens, such as, and a good one is relating it back to kind of like the fire service. When things burn, they tend to give off carcinogens. Okay, so what else?
Radiation from the sun.
Okay, that's environmental, right? Okay, and that could really come into where you live as well. Do you have is the sun essentially up more than it is in some areas versus others? Is it hotter in some areas versus others? What kind of lifestyle we're living in some areas? And then when we talk about, let's talk about that lifestyle. What does that mean? When we talk about some lifestyle, let's see, things that could affect diseases. What are we talking about with that?
Smokers.
Okay, so people that smoke. What else?
People that do drugs.
Okay, so illicit drug use. We have alcoholism. We
Alcohol.
have obesity. The way people eat. All these plays a role in how our body reacts and how we should treat our body. So genetic diseases are actually a lot harder to track down and identify and treat, just for the simple fact that it can go back many generations. When they can't figure out what's going on, does he remember what the word is called when it's a disease of unknown origin? What that word is that we refer to it as?
Idiopathic.
Yeah, idiopathic, absolutely. Now the thing that kind of sucks is we can't pick and choose who our parents are, right? We can't pick and choose who our relatives are. So we're kind of stuck with that when we look at like effects on individuals. Now, if we're talking about effects on populations, we're talking about diseases that might primarily affect somebody in the U.S., that might primarily affect somebody in Africa, that might primarily affect somebody in Europe. So when we talk about diseases, what is something that African Americans are more prone to obtaining, or more prone to essentially passing down the line?
Sickle cell.
Yeah, sickle cell, right? And when we talk about like Europeans, believe it or not, one of the things that is more prone to somebody that has strong European ties would be like cystic fibrosis. Believe it or not, here in the US, we have a strong tendency to develop cancer, not just based off genetics, but based off of the environmental and the lifestyle factors around us. But when we look at genetic diseases, they could be caused by genes, right? It could be either a single gene or a multiple gene. Single ones are a lot easier to track down and identify versus a one that's a little more complex. But let's take diabetes, for example. Passed down through generations, but it's not just passed down, or not just, what's the word I'm looking for? Oh, altered based off genetics, but it's mostly environmental and lifestyle factors, right? I mean, what's the thing you can think of if somebody goes to the doctor and they find out they have diabetes? What does their doctor recommend to them before medication?
Exercise.
Yeah, exercise, dieting. Let's change the way we're living before we start turning to medications. Even though it can be genetic, a lot of genetic diseases also have um, a part where we can maybe modify it a little bit just based off of how we're living and the lifestyle that we choose to abide by. All right, so some of the disorders and some of the risk factors. So immunologic disorders, that could be anything such as like allergies, asthma, something that it's pretty easy to deal with, but also pretty common, right? Then when we talk about cancers, cancers can be passed down. If you have a strong family tie, I hate to say it, to cancer, maybe generations before you passed away from like liver cancer or kidney cancer or something like that, it can tend to move down the line, and it tends to really cluster in families. But it kind of depends on what type of cancer we're talking about. Such as like lung cancer is more strongly identified with environmental causes. So what are some environmental causes that can lead to an increase for lung cancer? Well, obviously we know smoking, we know carcinogens. These are all things that we don't think about that can really hurt us. The bad part is you turn on the TV any day this week and you'll see some lawsuit thing come out by some attorney saying that you know this certain product could potentially cause cancer. This could potentially cause cancer. That could potentially cause cancer. Seems like anything this day and age could potentially cause cancer. When we look at endocrine disorders, what's the first thing you think of? Diabetes, right? But what does diabetes potentially lead to? It leads to other diseases. It's really just a gateway to the thing. So what are some things that that can lead to?
Can lead to kidney problems.
Kidney problems, kidney failure, kidney death, right? Diabetes, if we potentially have an increase in sugar, what can happen to our blood vessels over time? So I mean, what things could be caused by that? Maybe cardiac, maybe early onset dementia, early onset Alzheimer's. Diabetes is really complex and it's not exactly really understood yet, but we essentially know how to treat it. Now, there's a couple different types of diabetes, right? There's type 1 and type 2, which are the major ones that we usually deal with. Type 1 could also be called what?
Juvenile diabetes.
Juvenile diabetes, because it generally happens before, age 30 to 40. So that's what type 1 is, what's known as insulin dependent, right? Their body is producing no or almost no insulin. So those are the people that have to take injections every day. And we talk about injections, that's really progressed as well. You used to have to get a little vial, you used to have to drop your insulin, give it to yourself in the stomach. Now it's coming almost like an EpiPen where it's pre-measured. You just turn a dial and inject it with a small needle. It's really no big deal at all. So type 1 is going to be our insulin dependent. Type 2 tends to come later on in life. And it actually has stronger ties with families. That's the one that's most passed down than anything else. With type 2, it differs a little bit, right? We just have a decrease in insulin production. So some of our lifestyle factors, such as diet and exercise, might be things that we can change to try to alter this type 2 diabetes, right? Generally, people with severe obesity at some point will end up developing type 2 diabetes. But again, we try to control with diet and exercise. And if not, then we would look at possibly an oral medication. What are some that we see in the field commonly when we see somebody taking an oral medication for diabetes?
Metformin.
That's probably the most common one, right? Then we look at hematologic disorders. So when we talk about hematologic, we're obviously talking about blood. So what are some disorders that that are affected and have to do with the blood?
Anemia.
Anemia. Okay. Shane, I know you're on here, and I know which one I'm going to call out. Which one are you thinking of?
Sickle cell disease.
Okay, sickle cell. What else?
Hemophilia.
Hemophilia. That's what I'm going for. So, does anybody know what hemophilia is? It's really it's a clotting factor deficiency. It's not necessarily they have thin blood. They just don't have the fibrin in their blood to create clots like a normal person would, right? So the issue with that is, if you go to start an IV on someone with hemophilia, okay, everything goes like it normally should, and then you start noticing severe bruising around the site. That's not because the blood is super thin. It's just because they don't have that clotting factor, okay? What this can also lead to is bleeding in the joints. Why is that a concern? Well, we try to keep blood in vessels. Usually when it's leaking out somewhere, it's not what we're hoping for. But believe it or not, hemophilia is most likely driven from your mother. And affects males for some reason more than anything. There's not a cure for it, but if we know it's not thin blood, it's just a lack of fibrin, how do you think they can essentially treat hemophilia then?
Supplemental fibrin.
Yeah, supplemental clotting factors, absolutely. Maybe a blood transfusion to help try to fix what's going on. And then from hematologic, we go down to a pretty big one, right? Cardiovascular issues. Why is it important to ask? We have somebody, let me play this out for you guys. We have somebody, you respond to a 40-year-old having chest pain. You get there, they have no history of cardiac problems. You have them in the back of the ambulance. You do 12 lead, you do your paramagician stuff, right? And then come to find out that this person's dad and brother both died of cardiac issues. Why does that play a big toll into how we treat them?
Because this could just be the issue.
Yeah, cardiovascular disease is passed down in through generations. And again, that's something we can try to change. But if that's you're almost destined to have cardiac issues. One a good friend of mine, he's in his early 40s, healthy. I mean, exercises every day. You'd never know that he's had any issues before. Has had 3 heart attacks. I mean, he doesn't eat anything out of line. He again exercises every day. But his dad actually died of cardiac issues in his mid 50s. And there's this guy who weighs 130 pounds who goes running every day, actually works in the athletic field, and has 3 heart attacks by the time he's 40. Not because of lifestyle factors, but just based off of bad genetics. But there's other things as well that can play into genetics or play into cardiovascular issues. And we think of like hypertension, right? High blood pressure. High blood pressure is an issue because your heart has to pump against that for so long, right? Your heart has to try to overcome that pressure to be able to push blood out, which we call afterload, which we'll go through here shortly. 40% of all hypertension cases are related to bad genetics. What's the one thing if you have high blood pressure they tell you not to eat? Or you should limit?
Sodium.
Why? Why should we limit sodium?
High levels of sodium equal retention of fluids.
Yeah. Water follows salt naturally. That's just how it is. That's why they ever say if you're lost at sea, don't drink ocean water because it's so full of salt, it'll actually dehydrate you more than anything. Something to think of. Hypertension can be treated pretty easily with diet and exercise and also medications such as, our beta blockers. Anything that ends in LOL is a beta blocker. And not all cases of hypertension have genetic components. They're not all passed down. I guarantee a lot of your obese patients will probably have high blood pressure, but there also are some anomalies. I'm going to use me as an example. I'm a big guy. I have lower blood pressure than normal. On average, my blood pressure is like 110 systolic. So just remember, just because it walks like a duck and talks like a duck doesn't necessarily mean that's what it is. Renal disorders, we have kidney failure, which could also be caused by hypertension, right? It could be caused by blood clotting disorders. It could be caused by diabetes. How many of you have ever picked up a patient that is receiving dialysis? Has anybody ever maybe even transferred somebody to a dialysis clinic or dealt with somebody that has a history of dialysis?
Yes.
Okay, what did they call for? Do you remember?
Uh,
Or why you were transporting him?
the one that I can think of, we were transporting because she couldn't walk due to the fluid retention.
Did she miss a dialysis appointment?
She missed 2.
Missed 2 dialysis appointments. So dialysis is something that we frequently deal with in EMS. And I'm not saying that's something we do, it's the patients we deal with. Either receiving dialysis or maybe they missed a dialysis appointment. Let me tell you a quick story. Recently, I had a patient. Oh, actually, not recently. It was probably 3-4 months ago. We get called. Patient is unresponsive. Has a blood sugar of 47. I want to say roughly. So I'm like, oh, this is easy enough. There was no family around. I'm like, okay, we'll start an IV. We'll give D50. No big deal. My partner started an IV in one arm. Gave D50. He wasn't coming to. So we got him in the back of the ambulance. I started another IV in the other arm, except when I stuck him, it was almost like I hit an artery. And that's even what I said is I was like, I think I hit an artery because it was like literally spraying out no matter how much I occluded that vein. So I left it locked, got to the hospital, said, hey, I might have accidentally started an art line. Accidentally, just so you guys know, that's what that is. About 5 minutes in, I'm making my cot and everything, and the nurse comes out. And she goes, hey, that wasn't an art line you hit. It was a fistula. What is a fistula? Does anybody know? In dialysis patients, it's where they tie a vein and an artery together because that's essentially the spot where they're receiving dialysis through. So when I started this IV, I hit a vein, but the vein was attached to an artery, and I got a huge backup of pressure. And it's not the best thing. So how can we check for fistulas? Does anybody know that as well? It's the same as checking for an artery. So what do we look for?
Check to see if it has a pulse.
Check to see if it has a pulse. You can feel, and you can actually listen. If you feel that and the person says they're receiving dialysis, use it as a tool to teach yourself something. Grab your stethoscope and put it over that. You'll actually hear the movement of fluid through that small vessel. It's kind of neat.
And the
In line,
feel are like vibrations. So, and those are
yeah.
thrills, right? So
Do what? Sorry,
fish-
you were cutting out.
what?
You were cutting out. Sorry, what'd you say?
It's the one you feel is called a thrill.
Yeah, yep, absolutely, yep. And you might have heard the term bruit as well.
Yes.
Spelled B-U-R-I-T.
That's the one you can hear.
Yep. Now, kidney failure can also, if it causes a backup of fluid, and let's say we're talking electrolyte abnormalities at this time as well, this can cause some patients to have cardiac anomalies. Because remember, our heart runs off something called the sodium-potassium pump. So if I have a buildup of sodium or a buildup of potassium and that pump isn't working like it should, I could cause some serious cardiac issues up to leading up to potentially cardiac arrest just based off electrolytes alone. Rheumatic disorders. Gout's a good one. You get massive pain. Your feet actually might swell up or your toes might swell up. Most commonly, it's actually your big toe. Does anybody know what's causing gout by chance? Has anybody ever had gout?
Isn't it inflammation of the joints?
No, but there's a specific reason that there's inflammation. And it's because you have these essentially crystals built up, right? And these crystals are really just deposits of uric acid. So we have gout, it's because we have a high level of uric acid because our kidneys aren't functioning like they should, or they're maybe just backed up and not able to function like they should. So that's what causes the extreme pain is in those joints, we get these crystal buildups, very similar to sickle cell. You know, sickle cell causes extreme pain in patients because those blood cells are shaped like sickles, right? They're half crescent moons. So they're really sharp and they hurt while they're going through the blood vessels. It's the same thing with gout. We have these crystallized, it's the same thing with kidney stones as well. Renal calculi is the other term for kidney stones. Gout can be controlled through diet, or it can be genetic, or it could be environmental as well. What's one thing that, they used to call the gout rich man's disease? Why would they say that? What's one food group essentially that promotes gout if you eat a lot of it? Oh, I know somebody knows it. Don't be shy. It's red meat. That's why they call it the rich man's disease. All right, GI disorders, lactose intolerance, Crohn's disease. Crohn's disease, inflammation of the digestive tract due to an unknown cause. Does anybody know anybody with Crohn's disease? Or maybe like ulcerative colitis?
Yes.
Now, there's certain foods they can't eat, correct?
Ooh, that I don't know.
Okay. Generally, there's certain foods they can't eat. I actually worked with somebody. There's a couple people on here that worked with someone that they can't eat certain food groups because it actually affects their digestive tract, usually caused by an inflammation of whatever is passing through because their stomach doesn't agree with it. So they get this buildup of stomach acid or this buildup of digestive juices, if you will, that actually causes inflammation of the stomach and the intestinal tract. Ulcers is another one. Ulcers can be developed through eating spicy food, something as simple as spicy food, for long periods of time. Neuro disorders such as MS. Now, I talked a little bit briefly last class about nerves, right? And how we have that, your axons, the little highway that your nerves send signals down. Well, around that is a myelin sheath. MS affects that myelin sheath. So over time, unless treated, that myelin sheath begins to break down. And that's where you'll see potentially these patients with MS that's untreated potentially become paralyzed because, again, it's breaking down those nerve highways. Alzheimer's is another one, or progressive mental deterioration. And then, of course, psychiatric disorders, something that we commonly deal with in EMS. What are some examples of psychiatric disorders?
Paranoid schizophrenic.
Schizophrenia, a huge one, right? Bipolar disorder, absolutely. There was a big push for years on how we treated patients with schizophrenia and how we treated patients with bipolar disorder and that special term, excited delirium. We were treating them with benzos for the longest time. And the problem is it was taking high doses of benzos. So they said, hey, what can we do differently? And that's really where ketamine started to come back into the picture, because ketamine wouldn't essentially sedate them, but it would put them in a trance-like state. Does anybody remember, God, maybe 10 years ago when apparently bath salts was a big thing? Does anybody remember that whole ordeal?
Yeah, I remember that.
You remember that in Miami, that guy like bit somebody's face off under an overpass?
Yeah, we got all excited. We finally thought the zombies were coming.
Yeah, exactly. He thought zombies were coming after him, and he was on bath salts, and it put him in a almost schizophrenic, excited delirium. Now, what happens is, unfortunately, as EMS professionals, sure, we're trained on this. We're trained on how to try to talk somebody down and then, medically restrain them if needed. The problem is, who's the first one to a scene with somebody that's violent and schizophrenic?
Cops.
Yeah, and what do they usually do? What's one of the first things that, before recent years, they would try to de-escalate the situation, right? And if de-escalation didn't work and they tried going at, somebody tried running at them, what would they do at that point?
Shoot them.
Think less lethal.
Taser.
Taser, right? And the problem is, these people were so hopped up, their heart rate was already elevated, their blood pressure was high. Now we're inducing electricity to their bodies. What do you think was happening to their hearts? We were essentially shutting their hearts down because we were introducing electricity. Remember, our hearts run off automaticity. Our heart is the only organ that generates its own electricity. So when we're inducing volts like that, we can essentially stop the heart. It's kind of like what an AED does, really, when you think about it. What we're also going to talk about is shock. This is super important that we learn to pick up on different signs of shock, different stages of shock. Shock is defined as hypoperfusion. So we talk about hypoperfusion. Obviously, perfusion is movement of blood throughout the body. Not just the blood, but we're moving oxygen as well, and we're moving nutrients, right? So when we talk about shock, there's different types that is affecting blood flow. And there's different ways that we look at what can eventually put somebody in shock. We have, what are some different types of shock that you guys can think of?
Septic.
Okay, septic, usually caused by an infection, right? We can have septic shock, and we can have something called septicemia, which is an infection of the blood. What else? What are some other ones?
Neurologic.
Okay, neurologic. What is neurologic shock? What causes neurologic shock? What's the stem of that?
Damage to the spinal cord or brainstem.
Damage to the spinal cord or brainstem, right? And what happens is our body goes into shock because we lose the ability to regulate our blood vessels. We lose the ability to regulate our own blood pressure at that point. So if we can't manage our blood vessels, they just freely dilate. Remember, if we get massive vasodilation, massive opening of these blood vessels in our body, our blood pressure drops. So that we essentially go into shock. What are some other ones?
Hypovolemic.
Hypovolemic shock due to fluid loss, right? Okay, what else? I'm going to ask all until I get all of them answered. What about cardiogenic? Has anybody ever heard of cardiogenic shock? Basically a pump problem, right? Our heart is failing. It's not able to push the blood out needed to perfuse the organs within the body. We have anaphylactic, so shock caused by a severe allergic reaction. When we talk about shock, again, inadequate perfusion of the body tissue. So maybe our organs or whatever it might be aren't receiving the blood they need to function. There are three things that really define and really that we have to look at when we're talking in terms of shock. It is either a pump problem, it is either a fluid problem, or it is a container problem. Those are the big three: pump, fluid, and container. So when we talk about pump problem, maybe the heart itself is failing, such as CHF, such as an MI, such as a heart attack, such as cardiac death. It's a fluid problem, maybe due to fluid loss, maybe in a trauma situation, maybe dehydration, hypovolemia. Or it's a container problem, such as neurogenic shock. Our blood vessels, we aren't able to control them anymore. So now they're freely dilated. Those are the three things that really, one of those three things will always have to do with shock. It's always going to be one of those three things that are causing shock in a patient. So remember that: the pump, the fluid, or the container. And here's how our body works, right? We're a closed loop system. We have our heart, which receives blood. Okay. We receive deoxygenated blood to the right side of our heart. We then pump that blood through what's called a tricuspid valve. Our tricuspid valve separates our right atrium and our right ventricle. From our right ventricle, we pump blood up into our lungs, essentially, right? It does its thing. You can see our capillary beds there on the right side and left side. We exchange oxygen poor blood for oxygen rich blood. It then comes back to the left side of the heart. We go over left atrium, then our bicuspid valve down to our left ventricle. From our left ventricle, we go out through our aorta, and then our blood is pushed out to our body. And then it just repeats the same cycle. If you think about that, all that is being done 60 to 100 times a minute. It's kind of shocking to think of. I like hearts, and I don't know why that just trips me out every time I look at it. So the heart receives blood from the venous system, right? That's why we start IVs in the direction we do. We always start an IV facing the heart because blood is traveling in that direction. It also moves blood to our peripheral tissues. The amount of blood that is ejected by the heart with one contraction, so one squeeze of the heart, is referred to as a stroke volume. Okay, one stroke, the amount of blood that I'm moving in one stroke or one contraction of the heart. Preload is when the heart fills. So when the heart is at rest, it's also referred to as diastole. That is what we refer to as preload. That's the amount of blood coming back into the heart. Preload also depends on venous return. So let's think about this. If I have trauma and I'm losing blood and I'm not able to bring enough blood back to the heart is essentially an engine that's running out of oil at that point, right? What happens to an engine, a car engine, if you deplete it of its oil and keep asking it to do what it's doing?
What's that?
It'll overheat and it'll eventually lock up. It's no different than our heart, right? I went through paramedic school. I worked as a mechanic when I was actually going through paramedic school, and I related the car engine and the car vehicle systems, back to the body because they're all very similar. We have something called cardiac contractile force. Okay. This is the amount of force it takes to squeeze, right? And it has to do with afterload. Afterload is the amount of blood in which we have to overcome to squeeze the heart. So you got to think, the higher the blood pressure somebody has, let's take a blood pressure 170 over 80 roughly. The heart has to pump that much harder to overcome that pressure of 170 to get blood out to the body. Otherwise, it's not doing anything. When think of our blood vessels, when our blood vessels are constricted, and our body can do this automatically without us doing it, right? If our blood vessels are constricted, that can lead to increase in pressure. The greater the preload, the greater the stroke volume. So if I have more blood coming in, the greater I'm going to push out, right? So preload directly affects afterload when it talks to the heart. So again, our contractile force is how far we need to stretch our ventricles to overcome high blood pressure. And this is super important. Write this down. Remember, I don't care. When we talk about contractility with the heart, we're referring to something called Frank Starling's law, or Frank Starling's principle, or mechanism. Good example of that. The more a rubber band is stretched, the greater the velocity it has when it's released, right? If I take a rubber band, I put it on my thumb, and I pull it back 10 inches, when I go to let go of it, how far is it going to go? It could go 10 feet, right? If I take a rubber band and pull it back an inch and let go of it, it's probably just going to fall down right in front of me. It's the same principle when we're talking about a heart. Contractility is also affected by natural catecholamines that we have in our body. Remember, catecholamines are natural hormones. In this case, it's epinephrine and norepinephrine. Why is epinephrine a big deal when it comes to contractility? What do you think epi does? The other word for epi is adrenaline. What does it do to the heart?
Speeds it up.
Okay, speeds it up. So let's talk our receptor sites. We talked briefly earlier on in your paramedic education about receptor sites, right? Which receptor sites do you think epinephrine and norepinephrine play on? So remember, we have alpha, beta 1, and beta 2. Which one do you think they play a role on?
Beta 1.
Alpha.
It's actually alpha and beta 1, really, and beta 2. But primarily, we're talking about contractility, we're looking at beta 1. So who can remember which those receptor sites and what do they do? So let's talk about alpha for a second. What does alpha do?
Has to do with the blood vessels.
Okay, so alpha 1 is vasoconstriction. You're absolutely right. It brings our it collapses our blood vessels, okay? What about beta 1?
That's the heart,
Yeah, increased heart rate. And beta 2?
lungs.
Yeah, bronchoconstriction. Remember, 1 heart, 2 lungs. Beta 1, beta 2. Beta 1, 1 heart, beta 2, 2 lungs. So afterload, again, the resistance against which our heart must overcome to get blood out of it, can be directly affected by those blood vessels, right? So you got to think the greater the resistance that those blood vessels have, the more constricted they are, the harder this has to push. Think about this for an example. Let's think of a toilet paper roll. If I was to blow through a toilet paper roll, is it pretty easy? Right? I can inhale and exhale pretty easily through a toilet paper roll, right? Now, if I want to get the same amount of air out, except I want to blow through a straw, I'm going to have to use that much more pressure to get that air out, right? And it's going to take that much more pressure to get that air back in. It's the same principle when we talk about afterload. So cardiac output, the amount of blood pumped by the heart in 1 minute. Generally, we're looking at 60 to 100 contractions in 1 minute, right? Heart moves fast. How we determine cardiac output is we take stroke volume times our heart rate. I would remember that as well, if I were you. SV times HR equals CO is what you might see it abbreviated as. Our blood pressure is dependent on cardiac output. If our heart is working properly like it should, and we have decent vascular resistance, we should have a normal blood pressure. But as that vascular resistance increases, as those blood vessels constrict or as they dilate, our blood pressure can either raise or can lower. Again, think of the toilet paper roll versus the straw. And that's what our heart has to try to overcome. So how this works is we have baroreceptors. Think of shock for a second. We have baroreceptors in our carotid artery and in our aorta, which closely monitor blood pressure. They're essentially, think of us as a tank of water, right? And we have these sensors all around the tank. And as the fluid level begins to drop in the tank, these sensors pick up on it. So they now turn the pump on. We got to refill this tank. So how do we refill it faster? We turn the pump up. We make the RPMs go faster. It's no different. As the tank fills up, the sensors see that, they start to slow the pump down. That's how our body works with compensation with the heart. As it sees a drop in blood pressure or as it sees an increase in blood pressure, it will alter our heart rate. That is why some patients, when we talk about compensated shock here in a little bit, that's what you're looking for, is you'll see an increased heart rate, but maybe a little bit lower blood pressure. Also, our body again releases epi and norepi, which helps raise our blood pressure if needed as well. You got to think when we get an adrenaline dump, which we all work in as a first responder, we're no stranger to adrenaline dumps. Every time we go to a call, every time we get toned out, every time we hear the word CPR in progress, we get an adrenaline dump. What happens to your blood pressure? Because I can tell you there was a study done on firefighters, and it was what happens to them in the middle of the night when they're woke up to tones. And they did a sleep study on them, and they took their blood pressure right before they went to bed, and then blood pressure right after getting back from a call. What do you think the toll it took on them was? What do you think happened?
Massive increase in blood pressure.
Massive increase in blood pressure. And then here's the bad part. How many of you have ever been going to a call and then you get disregarded to it? What happens to that adrenaline? It dumps off, right? It's not good for our bodies. Blood flows a lot more slowly than water. It's a lot more viscous than water. It's also more adhesive than water. So that saying, blood's thicker than water, they're not lying. All right, so blood transports oxygen, carbon dioxide, nutrients, hormones, waste products, and heat, right? How does blood transport heat? Actually, you know what? How does blood and blood vessels primarily, how does that have a role in heat regulation within our body?
It'll constrict everything. If you're too cold, it'll constrict everything away from your extremities, keeping it to your core.
Okay. So let's take this for example. I'm at Adventureland where it's 170 degrees every single day you're there. I don't care what anybody says. But I'm in Adventureland and I start to become overheated. What happens to my skin? What color do I start to look?
Red.
I start to look red. Why is that? It's not because I'm sunburned, because I'm pale. What else?
You
Your
vasodilate.
capillaries opening up.
I vasodilate. My blood vessels open up, right? I'm turning red because all that blood is being brought to the surface of me. And Nate, you're absolutely right. What happens if it is negative 20 degrees outside right now and I step outside and I'm out there for 10 minutes? What color am I when I come back in? I'm pale because my body has constricted all my blood vessels to conserve heat to my core. It's actually pretty ingenious when you think about it. We're like little robots. So we need an adequate amount of blood required for perfusion as well as heat control when you think about it. We're also going to talk about something called natriuretic peptides, or NPs, which help with long-term regulation of sodium and water balance. And we're going to talk about something called the RAAS system. So, since our heart, our cardiovascular system, is a closed system, the volume of blood present must be adequate enough to fill the container. When we talk about containers, we're talking about blood vessels, okay? We have what is called ANPs, atrial natriuretic peptides. And we have BNPs, brain natriuretic peptides. ANPs are stored and released by the heart's muscles in response to such things such as atrial distension. So when our atrium begins to stretch, okay? BNPs are released whenever our ventricles begin to stretch. So it's essentially a response. Whenever there is a stretch, we start to release these peptides. These peptides will then essentially go through and change either vasodilation or change our sympathetic system or parasympathetic system. So if this starts to see our heart working too hard, it will say, hey, let's dilate out a little bit. Let's make it a little bit easier on our heart. Our heart's struggling a little bit. We also have what's called the RAAS system. Okay. What the RAAS system is, and I would probably remember this as well, it's the renin aldosterone angiotensin system. A lot of words that mean nothing as of right now. What they do is it says, hey, I'm in shock. My blood pressure's dropping. I'm going to hold on to sodium. Why do I hold on to sodium again?
To help retain water.
To help retain water. Absolutely. Or if it sees a rise in blood pressure, it can say, hey, let's get rid of more salt than we normally would. Because we want to drop, we're going a little bit high. We want to drop it down a little bit. This affects what's called our GFR, or our glomerular filtration rate. Okay, this is what helps us filter out our urine. It decreases renin, which is one of these hormones, by decreasing angiotensin 2, which results in a reduction of blood volume and thus a reduction in central venous pressure. Before I have a video I want you guys to watch. Before I click this video, let's take a 10-minute break, and then we'll come back. We'll watch this video. It's about 7 minutes, and it talks just about the RAS system. She explains it a lot better than I could. So take 10 minutes. We'll come back at 7, and we'll watch this video, okay? All right. Apparently my clock is off. Anybody still at break, or is everybody ready to go? All right, so we're gonna watch this video. Like I said, it's about 7 minutes long. She does a really good job of explaining how the renin, angiotensin, aldosterone system works, and has it up on a whiteboard. Again, I'm a person that I have to see pictures before I truly remember something. I'm not able to just look at it and retain it. So if you're kind of like me, this might help you a little bit. Let me know if you guys are able to see this and if you can hear it while it's going, please.
Can't hear it.
Yeah, I can't hear it.
You can't or can?
Can't.
Cannot.
Let me know.
Before you get done
Any
watching
better
this
now?
YouTube video, you can access a free quiz that will test you on this system. So let's get started. What does this system
hear
do?
now.
And what is its whole goal? Well, the RAP
We can hear it.
Okay, perfect.
system, what it does is it manages our blood pressure, specifically when that blood pressure drops. So what it's going to do is it's going to kick into gear, and it's going to increase the blood pressure by getting a naturally occurring substance on board in the body called angiotensin 2. So that is the whole goal of this system, is to get angiotensin 2 activated and functioning to help cause major vasoconstriction in the body, because when we constrict vessels, we increase blood pressure. Plus, angiotensin 2 will help increase our blood volume as well, which will also increase our pressure. So let's go through this system step by step until we get to the end result, angiotensin 2. Now, as we study this, really let the names of these substances help you out, because it's called the renin, angiotensin, aldosterone system. And this is really the sequence of how these substances are released. So very first thing happens, our blood pressure drops. The body senses this and says, oh no, we've got to deal with this. So the sympathetic nervous system is stimulated. And remember, this is our fight or flight system that helps save our life. So these nerves stimulate the kidney, specifically these cells called juxtaglomerular cells, also called JG cells. And these cells are stimulated and they will release a substance called renin, which is the first part of our system. So renin enters into circulation. Now, as it's floating through circulation, it's going to do something. It's going to activate a substance in the liver called angiotensinogen. And once this substance is activated because of this renin, it is going to turn into angiotensin 1. Now, remember, we need to get to angiotensin 2. So we have angiotensin, so we're in the second part of our whole system name. And since this angiotensin is in the system, in the vessels, it is going to really get this ACE involved, because we need ACE. ACE is going to help us convert angiotensin 1 into angiotensin 2. So ACE stands for angiotensin converting enzyme. So it's going to convert it for us. And this ACE is found on the...
I want to stop that for a second. Who's heard of ACE inhibitors for a medication? Kind of makes sense. ACE inhibitors are used to control blood pressure. Well, now that we look at that, and that's an enzyme having to do with controlling blood pressure, it kind of makes sense a little bit.
The surface of the lung and kidneys in the endothelium. So it's going to convert our angiotensin 1 to angiotensin 2. Now we're here. We have this awesome active vasoconstrictor agent in our body that's going to help us increase our blood pressure. But how does it do that? We need to talk about aldosterone, right? Okay, so angiotensin 2, it's going to act on our smooth muscle vessels, it's going to constrict our vessels. When we constrict vessels, that's going to increase systemic vascular resistance and increase our blood pressure. To help you visualize it or understand it, think about a water hose. When we take that water hose and we narrow it, what happens to the pressure of the water coming out? It's really going to increase. Now, another way we can increase the water, the pressure coming out of that water hose is if we increase the volume of the amount of water coming out of that hose. So if we go to that faucet, turn it up, that's going to increase the pressure even more. So that's what this angiotensin II is also going to do. So it's not only going to constrict our vessels, but it's going to help increase blood volume. Now, how does it do this? Well, it stimulates some other things. Number one, our kidneys are going to be stimulated. Kidneys are going to start conserving sodium and water at those tubular sites within the nephron. And it's influenced by also another substance, which is produced by the adrenal cortex called aldosterone, which is the last part of the name of our system. Now, aldosterone, what is it going to do? It's going to also cause the kidneys to keep sodium and water, and it can also lower our potassium level because the kidneys will start to excrete it. Another gland that's going to be stimulated because of this angiotensin II is the pituitary gland, and it's going to release a substance called ADH, antidiuretic hormone, also called vasopressin. And what this substance does is it causes our kidneys to keep water. So we're keeping water, even more water. We're going to keep more water and sodium over here, and the kidneys are going to do that. So what it's going to do is it's going to increase the volume of blood, which is going to increase our blood pressure even more. So the end result of this RAS system, whenever it is working correctly, is we are going to increase our blood pressure. Now, in the previous lecture, we talked about ACE inhibitors. And these medications, what do? They help lower the blood pressure. And right here, what ACE inhibitors do, they prevent this ACE, the angiotensin converting enzyme, from working. And so you don't get the conversion of angiotensin 1 to angiotensin 2, so we have lower blood pressure. Now let's illustrate this and do a quick recap of this RAS system so it will stick in your mind. So we have that drop in blood pressure. Sympathetic nervous system is stimulated, which will send nerve impulses to those JG cells in the kidneys, which will cause them to release renin into the circulation. When renin is present in the circulation, it's going to activate a substance in the liver called angiotensinogen, and this will turn into angiotensin 1. Now we want angiotensin 1 to turn into that active vasoconstrictor. So to do that, you have to have ACE, which is angiotensin converting enzyme. And remember, this was found on the endothelium in the lung and the kidneys. So ACE will turn angiotensin 1 into angiotensin 2. And angiotensin 2, it's going to have some effects on the body. One thing it's going to do is it's going to cause vasoconstriction, so constrict those vessels. It's going to cause the kidneys to keep sodium and water, which is going to help increase blood volume. Also, you're going to have aldosterone being produced by that adrenal cortex, and that's found on top of the kidneys, and it's going to help the kidneys also keep sodium and water. But remember, potassium will be excreted. And then we also have the pituitary gland, who is going to produce antidiuretic hormone, ADH, and that's going to cause the body to keep water. All together, they want to increase blood volume, we're constricting vessels, and this angiotensin 2 is going to help us increase blood pressure. Okay, so that wraps up this review over the renin, angiotensin, aldosterone system. Thank you so much for watching. Don't forget to take the free quiz and to subscribe to our channel.
I don't expect you to remember all of that, but I will be uploading a worksheet probably tomorrow, which I expect you guys to complete for homework, as far as that little graph that she just showed you guys, that flow chart. And I want you to go through and label it. That way, it might help you retain some information about the RAS system and how it truly helps retain sodium, and how ADH, which is your antidiuretic hormone, prevents kidneys from functioning in the sense that we want to retain fluid to help raise blood pressure.
For more
Now if
videos.
I can get her to shut up and move to the next slide. Okay. All right. So let's talk a little bit about oxygen, because when we talk about perfusion, obviously oxygen is attached to hemoglobin, which is perfused throughout our whole body. Oxygen is brought into our body via the respiratory system. Every time we breathe, every time we inhale, we're bringing fresh oxygen in and we're letting carbon dioxide out. So how it works is, remember, we have capillary membranes at the bottom of our lungs within our alveoli, which exchange carbon dioxide and oxygen. How much, what the atmosphere wise, what percentage is generally oxygen?
2021.
21%. See, you guys are learning something. Blood comes into the pulmonary capillaries, return to the body, and return to the right atrium of the heart, right? And then pumped by the right ventricle into the pulmonary arteries, then into the pulmonary capillaries. So it's almost just a big circle is how our body functions. Red blood cells carry oxygen. More importantly, hemoglobin carries oxygen, but remember, hemoglobin can also carry carbon dioxide. Carbon dioxide is actually more prone to hemoglobin than oxygen is. What's another word? A little pop quiz here. What's another word for red blood cells?
Erythrocytes.
Erythrocytes. Look at, I am proud. Who said that? All right. So we have what's called the Fick principle, and this is what is needed for oxygen to be utilized in the body. So we have adequate inspired oxygen. So that means we're bringing enough oxygen into our respiratory system. We have to have appropriate movement of oxygen across the in the arterial bloodstream. So then we kind of have to have blood movement then, right? We can't really essentially be in shock. It kind of makes sense now when you think of some trauma patients or some trauma cases, which we might go through next semester, especially dealing with PHTLS, why you see some trauma patients with low pulse oxes. Why would their pulse ox be low? It doesn't make sense. It's not a respiratory problem. It's a trauma problem. So why is their pulse ox low?
Low blood cell count.
Due to what?
Blood loss.
Due to blood loss, right? We lose blood, we lose hemoglobin. So that's where you will see essentially patients. It's not because they're essentially hypoxic, it's just they don't have the hemoglobin to transport the oxygen. We also have to have that adequate number of red blood cells, right? The erythrocytes, like was said earlier. We have to have proper tissue perfusion. So for proper tissue perfusion, we have to have our blood vessels that are acting accordingly, that are dilating, that are constricting. We have to have good blood pressure. Really good indicator. Remember, I don't know if I taught you guys or not. If I can feel a pulse at my carotid artery, my blood pressure is at least 60 systolic. If I can feel one at my brachial artery, my blood pressure is at least 70. If I can feel my blood pressure at my radial artery, it's at least 80 systolic. Just a good rule of thumb. And then we obviously offload oxygen at the tissue level, because ATP, or energy, what are the two things that create energy? The two main things.
Oxygen and glucose.
Oxygen and glucose. And glucose we'll get to here shortly. Absolutely. So let's look at how gas exchange works.
Lungs are infoldings of the body surface that are used for gas exchange. The lungs of mammals are divided into tiny sacs called alveoli. Deoxygenated blood flows through the capillaries that cover each alveolus. When air enters the respiratory tract and reaches an alveolus, oxygen diffuses across the respiratory surfaces. The blood is now oxygenated as it leaves the surrounding capillaries. The alveolus functions as an interface between air and blood. That interface consists of a layer of epithelial cells, some extracellular fluid, and the wall of a capillary. The capillary wall is so thin that oxygen and carbon dioxide readily cross it. The bloodstream distributes the oxygen from the lungs to the tissues that need it. The bloodstream also delivers the carbon dioxide from the tissues that generated this waste product to the lungs for expulsion.
Neat little video on how gas exchange works. I'll tell you what, this is like the bread and butter of paramedicine. It's learning your pathophysiology in terms of perfusion, in terms of shock, and in terms of carbon dioxide and oxygen. You know, the stuff that we're covering now, this is really, there's a reason we call it foundations. It's because this is really what you build your education on. So let's talk about a little more about hyperperfusion. Waste products of cellular metabolism carried away by blood, right? We know that waste products can be carbon dioxide, so we carry that away. It could be nutrients that are used up. So carbon dioxide leaves the bloodstream during oxygen carbon dioxide exchange in our lungs, right? In those capillary beds that we just looked at. Waste is then expelled also into the lymphatic system. Waste is then cleansed from the body via the kidneys, right? It goes through and picks the nutrients that is left over, puts it back into the body, and then it gets rid of the excess, maybe the acid, urea, through our urine, okay? Majority of carbon dioxide is transported in the form of bicarbonate. And I know I've said that word to you guys maybe a couple times. Bicarbonate ions are known as HCO3. So anytime you see HCO3, think bicarbonate. Carbon dioxide is ultimately eliminated when we exhale, okay? A majority of the carbon dioxide is coming out of our body when we are able to exhale. Remember, when we are breathing out, our diaphragm is rising and pushing the air out of our lungs. When we breathe in, our diaphragm lowers, allows us to pull in via negative pressure. Kind of makes sense why our respiratory system tries to compensate when there's an excess of carbon dioxide. So let me throw this one at you. For example, we've learned a little bit about end tidal. Normal range 35 to 45, right? We've learned a little bit about acid-based. So if I have a patient, let's say acid, their pH level is 7.33. Are they acidic or are they alkalytic?
Acidic.
Okay, they're acidic, right? They're low on the scale. Now let me throw an end tidal at you of 48. What does that mean? Are they holding on to too much or are they blowing too much off?
Holding on to too much.
They're holding on to too much. So how does the body try to get rid of that?
You breathe faster.
You breathe faster. Makes a little bit of sense why our respiratory system tries to get rid of that waste, right? We also have different buffer systems to help get rid of that. When the amounts of waste that our body's trying to get rid of increase, such as an increase in lactic acid, the tissues can then become acidotic, right? Anytime we have acid release into tissues, it's bad. Very similar to when we look at like crush injuries, right? We get a buildup of uric acid in our tissues. What happens is when that crush injury starts to be lifted off, that acid rushes into the bloodstream and can essentially put our patients in cardiac arrest. That's why we treat those patients that are in acidic states. That's why we treat them with sodium bicarb, is we're trying to correct an issue that their body cannot. But again, remember in those respiratory patients that their body's compensating, such as somebody that might have like Shine-Stokes respirations or Biot's respirations or Kussmaul respirations, their body is naturally trying to do the job. So if we go in there and try to upset that, we can essentially put our patients into what's called acute respiratory distress because we're offsetting a balance. Acute respiratory distress syndrome, also also referred to as ARDS. We'll kind of watch another little short video here on what ARDS is and what role it really takes on our patients and how we'll talk about how we can treat this afterwards. Something neat with ARDS, though, is when we think about all of our COVID patients that we're transporting or the patients that were in the ICU that were intubated, they were developing this. And we'll talk about that afterwards when you start to see why.
Typically in sepsis-induced ARDS, bacterial toxins arriving at the lungs in blood cause macrophages and neutrophils to adhere to capillary, endothelial, and alveolar cell surfaces. Lung damage is a result of a systemic process initiated by burn tissue, infection, or inflammation, rather than a direct lung injury, although inhalation damage may be causal too. The macrophages release a variety of substances that damage both the alveolar walls and the capillary endothelial walls. In response, the endothelial neutrophils release lysosomal enzymes that cause more damage, resulting in leaky membranes. The damaged capillary and alveolar walls become leaky, allowing plasma, proteins, and red blood cells to enter the interstitial space. As the interstitial fluid accumulates, the pressure rises and forces fluid into the alveoli through the spaces in the damaged walls. The pressure in the capillaries that normally drives fluid out of them into the interstitial space is usually counterbalanced by the osmotic pressure of the plasma proteins. Once these proteins are in the interstitial space, the pressure balance is disrupted with further net loss of plasma from the capillaries into the interstitial space and then into the alveoli. Protein-rich fluid accumulates in the alveoli and damages the surfactant-producing alveolar cells. As more and more surfactant is lost, the alveoli stiffen and collapse, so normal expansion and contraction stop. Decreased alveolar compliance, atelectasis, and fluid-filled alveoli interfere with the exchange of oxygen and carbon dioxide across the alveolar and capillary membranes. Blood oxygen levels fall. Carbon dioxide levels also fall, as the increased compensatory respiratory rate blows off more carbon dioxide. Fibrin from plasma and debris from dying cells combine to form stiff hyaline membranes which line the former alveolus, further reducing alveolar compliance and gas exchange. Blood carbon dioxide starts to rise, since it will not diffuse across the hyaline membranes, and oxygen levels decrease as no oxygen can enter the stiffened alveolus. This leads to respiratory failure and often death.
I like how she calls it respiratory. Okay, so a lot of COVID patients, again, I'm bringing this up because it's something familiar to us, were developing what secondary to COVID when they were in ICU?
Pneumonia.
Pneumonia, right? Pneumonia, we can also is an infection of the lungs, right? So what happens is when we have infection causes these membranes within inside the alveoli to be leaky, which essentially pulls fluid into those alveolar sacs, which essentially causes our patients to drown. Drowning in their own fluid. And it's nothing that we can do. That's why a lot of patients, they were putting on ventilators to try and blow some of this off because they could control it at that point instead of letting the body do it. That's why some of these patients were on ventilators for 30, 60 days. Some of them didn't even make it off a vent. Kind of makes sense as well. If I have a patient with fluid in their alveolar sacs, what is our go-to? What do we look at doing? CPAP, right? We try to push that fluid back into the vessels. We try to get that fluid out of where it is. What are some contraindications of CPAP? At least for us.
Low blood pressure.
Low blood pressure, right? Because as we put patients on CPAP, it causes an increase in intrathoracic pressure, right? We're pushing more air into that chest wall, that chest area, their intrathoracic space. As we do that, we put pressure on the aorta. We put pressure on the superior vena cava, so we reduce blood supply. What's another contraindication?
Altered mental status.
Altered mental status. Our patients have to be conscious and know what is going on before we can put them on CPAP. Absolutely. So when we talk about the pathophys of hypoperfusion, and let's refer to hypoperfusion as shock now, okay? Again, we have three things that are potentially causing this. Inadequate pump, so the heart's failing. Inadequate fluid, so we have fluid loss, we have dehydration, we have hypovolemia, or an inadequate container, so we've lost the ability to control our blood vessels. Potential causes of that, so we have infection, right? Potential septicemia, potential septic shock, trauma and hemorrhaging, okay? Loss of plasma through burns, severe cardiac arrhythmias, because that can control the pump working effectively, right? Central nervous system dysfunction. Those are all different types of shock. I'm looking at septic shock. I'm looking at neurogenic shock. I'm looking at hypovolemic shock, cardiogenic, and neurogenic. I just listed everything that those underlying causes pertain to. So the ultimate outcome of shock can impair cellular metabolism. And remember, there's two different ways that our cells can metabolize, right? They can function how they normally would, with or without what?
Oxygen.
With or without oxygen. So when we talk about with oxygen, what is that term we look at? What is that term called?
Aerobic.
Aerobic.
Aerobic. And then what's a term without oxygen?
Anaerobic.
Anaerobic, right? And meaning without. So the first stage, when we talk about like glucose down there at the bottom, primary energy source per cells is glucose, right? It's energy. The first stage of glucose breakdown is what we call glycolysis. Does not require oxygen, but it also produces very little energy. Glycolysis can be performed in anaerobic metabolism. Not a big deal. But there is a second stage of glucose breakdown that does require oxygen, where we now break down nutrients into carbon dioxide, into oxygen, into water, and into energy. If you guys have ever heard the term, that's what's called Krebs cycle. The energy yielded from the second stage, because the glucose is much higher than the first stage. Because again, we have oxygen, we're able to work more efficiently as opposed to working anaerobic without oxygen. Without oxygen, after glycolysis, glucose breakdown stops, okay? Our sodium potassium pumping mechanism fails, so our heart starts to go into shock. Our heart starts to fail. Our cell membranes rupture. What happens when our cell membranes rupture is we get cellular death. Now, something kind of interesting about glucose and how we can essentially bring somebody's sugar up. Dextrose is essentially straight syrup into somebody's veins, right? What is glucagon doing when we give glucagon? I think I've talked about this just briefly a couple times. When we give glucagon, what's happening? I want you to hold that thought. Hold that thought, because we're going to come back to it here shortly, okay? So, some factors that reduce delivery of oxygen to the cells, reduce delivery of glucose to the cells, right? Because we have these channels to deliver things to our cells. Any glucose, any sugar that cannot enter a cell remains in our bloodstream. That's how we get hyperglycemia. The excess of sugar. Think if I sit here and ate 10 candy bars straight, my body is only going to use so much for nutrients. The rest of it is going to turn into fat, and the excess glucose is just going to sit in my bloodstream. That's why if I test my blood, it would be extremely high at that point, right? I'm not testing my glucose stores in my liver. I'm just testing the amount of sugar in my blood. In the absence of glucose, your body can use glycogen stores. So our liver and our kidneys build up with something called glycogen stores. It's like our backup plan in case things go south, okay? Now, when we give glucagon, that little IM pen comes in a little red case, we are releasing those glycogen stores. Has anybody ever seen somebody give glucagon by chance? I've only given glucagon probably less than 5 times in my career, but it takes longer than dextrose because, again, you're giving it and you have to allow the liver and the kidneys to release their stores of built-up glucose. They naturally don't release this. They're very greedy, your liver and your kidney, when it comes to glycogen. So when I give this glucagon, I'm hoping that they release that glycogen. They're hoping that they release these stores. The problem is it takes a while for that to build back up. I have a patient that I frequently go to. That glucose, she has liver cancer. Glucose does nothing to her. We have to give her glucagon. Problem is, my service doesn't carry glucagon, so they are prescribed their own glucagon pen. Well, it happened 2 times in one night where I had given glucagon, got her come to within 10, 15 minutes. Again, it's a little bit slower. And within 4 or 5 hours, we were called back out there because, again, she had liver cancer. She couldn't process sugar the same. She didn't have the sugar buildup. She couldn't storing sugar that she needed to. So at that point, I went to give the glucagon again, did nothing. Did nothing, seriously, because she didn't have any glucose build up to save. So something to consider. When your body runs out of glucose, what do you think the next thing it turns to use as energy?
Would it be your muscle?
Fat.
Fat.
Who here's, I guarantee everybody here, who here has heard of a keto diet? So with a keto diet, you're reducing your carbohydrates, you're increasing your protein intake, and you're decreasing your sugar intake because you want your body to, instead of eating at sugar, you want it to eat at fat. That's how the keto diet works. Is it doesn't eat at sugar because you don't have any sugar stores to build up because you're eating a very minimal amount of sugar, so it naturally turns to fat. That's how you lose weight through the keto diet. The problem with that is over time, that can actually cause issues with you if you don't keep up on your proteins, because organ failure can develop due to lack of protein when it starts to turn to fat. That's why you have to eat such an excess amount of protein when you're on the keto diet. Impaired use of oxygen and glucose leads to cellular death. Absolutely. Remember, that's fuel for the cell. It needs oxygen, it needs glucose. Cellular death then leads to tissue death. Tissue death leads to organ failure. We have one organ fail, everything in line with that organ starts to fail as well. And from there, we have what's called MODS, or multiple organ dysfunction syndrome, or multiple organ failure, which then leads to death. Just a chart that I put up here for you guys, looking at impaired glucose usage and impaired oxygen usage, what it leads to, and how our body essentially responds to it. Again, you'll have this PowerPoint to look back on too. I load up all these recorded PowerPoints on D2L if you haven't seen them on there yet. So we've talked a lot about shock, right? In shock, we see a fall in cardiac output detected as a decrease in blood pressure by those receptors. Remember, we're a tank of water. Our sensors see a drop in blood pressure. They automatically try to correct that. It does that by activating certain body systems, okay? One, it activates that RAS system, that renin-aldosterone angiotensin system, which basically keeps salt and produces ADH, an antidiuretic hormone. It also stimulates our sympathetic system. Remember, sympathetic is our fight or flight system, as to where parasympathetic is our feed or breed. That's where we start to slow down. So when our sympathetic system is stimulated, it activates something called our adrenal cortex, which again releases epinephrine and norepinephrine. When we do that, we see an increase in heart rate, an increase in the pumping of our heart as far as contractility wise, and we see vasoconstriction. So we see alpha and beta 1 properties, okay, just used to elevate our blood pressure. Compensated shock. Our body tries to correct itself. When it sees something wrong, it tries to essentially use a buffer system to try and correct what's going on. Shane, I think you were the first one that picked up on it during our skills lab last Thursday night when I gave you guys a certain scenario. Let's say the heart rate was 135 and the blood pressure was 101/70. Just those two vital signs alone, you looked at that and said, okay, they're in compensated shock. How do you know they're still compensating versus decompensating?
Because the heart rate is still elevated.
The heart rate's still elevated. Absolutely. That's the easiest thing for us to look for. When we start to see a heart rate that's elevated and a blood pressure that's on the fence, such as 101/70, we're compensating at that point, right? When we start to see a heart rate that's maybe in the 80s or anything below tachy and a blood pressure that's falling, we're now decompensating. The body is now becoming too tired to function. Maybe it's due to a loss of oxygen, or maybe it's due to a loss of glucose. It's losing energy. So we go into a state, what's called decompensated shock. We also have what's called irreversible shock, where we can no longer correct what's going on. We no longer have the capability. In irreversible shock, this patient is going to die. There is no ifs, ands, or buts about it. Whether it be due to severe hemorrhaging, maybe due to heart stopping, maybe due to severe trauma, who knows, right? Cardiac depression. When we start to go into shock, remember, our heart rate will kick up, but our heart can only handle that for so long. We're not meant to beat along at that rate for that long. And we're not meant to pump like that for that long. Imagine this. If I have a heart beating 60 times a minute, and it's putting out, let's just say, 1 liter of blood. If I speed that heart rate up to double that, 120, how much blood do you think it's putting out then instead of 1 liter? Putting out more or less?
More.
Okay. Do you think there's a possibility? You're right, but now let's throw this in the mix. If I have reduced cardiac contractility, so I have reduced squeeze, am I putting out more or less then? I'm putting out less. Even though my heart's beating that fast, it's not getting the same amount of squeeze, right? I'm getting a smaller squeeze, but going faster. We also, due to fluid loss, due to blood pressure loss, due to oxygen loss or oxygen depletion and glucose depletion, can see depression of the center of the brain because our brain needs that glucose. It needs that oxygen to function. We start taking that away and we start to essentially, I don't know, the brain starts to die off to a point. And remember, we can go for 3 to 4 minutes without oxygen, but after that, we start killing brain cells. All right, so types of shock. I've talked a little bit about this. Cardiogenic, the inability of the heart to pump blood. Enough blood to supply body parts, I should say. Sure, it'll still pump even when it's dying, but it might not pump enough to keep your liver going. It might not pump enough to keep your gallbladder going. It might not pump enough to keep your lungs oxygenating, right? This is due to a left ventricular failure because remember, the left side of the heart pumps blood out to your body. Am I saying that's what the cause is? No. It could be a right-sided failure, but your left ventricular failure happens to be secondary to what's going on. How we can also tell if somebody is trending cardiogenic shock, presence of pulmonary edema. So we start to get backing up of fluid into the lungs. Or if we start to get back up of fluid into the extremities as well, right? Altered mental status. What is oliguria? Does anybody know?
Reduced urine output.
Okay. Why would that be a sign?
Your kidneys are failing due to the
due to not receiving blood, right?
Right.
Yeah. Hypovolemic shock, loss of intravascular fluid volume. What are some instances where we could see somebody in hypovolemia? It says it right on the screen.
Trauma.
Okay, trauma, right? But with trauma's got to be careful. Is it hypovolemic shock, secondary to neurogenic shock, or is it neurogenic shock causing it? What else?
Severe dehydration.
Severe dehydration, okay. What can cause severe dehydration? We're going down a rabbit hole now.
Burns.
Okay, burns. What else?
Your atmosphere, like kind of what you're doing, if you're outside working hard, or if you're
Okay, so environmental factors, we'll say.
Yeah.
Okay. What about nausea? What about vomiting and diarrhea with reduced fluid intake? Can that cause hypovolemic shock? Sure.
Absolutely.
DKA,
Yeah,
excessive sweating? Absolutely. What's funny is it says traumatic injury, long bone or open fractures. I mentioned it to part of the class Thursday night. If we have a patient that breaks their femur, how much blood can be lost due to a femur fracture before we notice it?
Isn't it about 2 liters?
1 to 2 liters, absolutely. That's scary considering our body only holds 6. Think if somebody breaks both their femurs. We've essentially lost over half the blood. So in these patients with hypovolemic shock, it doesn't have to be somebody that is outside running. It doesn't have to be somebody that, was in the desert or something like that. This could be your patients at a nursing home that have severe diarrhea and severe vomiting, but just haven't had a whole lot of fluid intake. They could potentially be altered. Their skin becomes pale, absolutely, because their vessels are constricting, trying to conserve what they have left. Blood pressure is normal because they're compensating, and then they fall when they start to decompensate. Pulse goes from rapid to slower to disappearing. So I look at that instead. I say compensated, decompensating, and irreversible. Urination output decreases because we don't have any fluid to filter. And cardiac arrhythmias may develop because electrolyte imbalances. Another thing to check with people that are potentially in hypovolemic shock is check a blood sugar. It's not off the wall. Neurogenic shock, injury to brain or spinal cord. So any injury to the spinal nervous system, we treat it the same, right? It's support of our ABCs, oxygenation if needed, ventilation if needed, maintenance of body temperature with any patient in shock, get IV access so we can maybe start to give them fluid replacements, right? When we talk about neurogenic shock, this isn't your basic, I got in a car accident, this person needs backboarded. No, this is my patient's in shock due to some form of trauma. And remember, you can have one form of trauma secondary to another. So I can have hypovolemic shock secondary to neurogenic. Anaphylactic, severe allergic response. These are the patients that require EpiPens, right? People just have a normal allergic responses. We just give Benadryl to. Has anybody ever been on a severe allergic reaction or heard of one where there was almost nothing that could be done? Or maybe their tongue had swelled up, or maybe they were unresponsive or anything like that?
Absolutely. He almost died and we ended up flying him.
Yeah, right. And it can take so much Effie sometimes to reverse what's going on with those patients. Death can occur before a patient can get to the hospital, right? Shane, I'm going to pick on you for a second. I know of a call your department had went on. I'm not going to give specifics of it, but what happened in that instance?
He had a delayed allergic reaction to some antibiotics that he was prescribed, and he was at a home in Carlisle, and he went to the bathroom. He'd been there a long time. Long story short, he went in severe anaphylactic shock and was unresponsive in the bathroom. When we found him, his tongue and airway was just about swollen shut by the time we got there. We gave him Epi, and he was able to wake up and talk to us, but they ended up RSIing him when we got to the hospital, and he almost didn't make it, but last I checked, he was still alive. So,
and you know what? That brings up a good point, is that those patients, when they have a severe allergic reaction right like that, you know what? We might have to secure the airway on them because we might lose it at some point, right? With anaphylactic shock, we get skin symptoms such as hives. We get respiratory symptoms such as wheezing, cardiovascular symptoms because we increase our heart rate due to our adrenaline dump, GI symptoms, nervous system. Our treatment is based solely around pharmacological interventions such as epinephrine. Septic shock. Generally, these patients have an infection or a history of a recent infection. It could be something as simple as bed sores. Also, look at their medication list. Do they have a history of antibiotics? Do they have a history of something to treat an infection? When we start looking at septicemia, which is sepsis of the blood, we've got a problem at that point. Again, it can send our patients into what's called multiple organ dysfunction syndrome. When that happens, we're fighting a battle that is going to be an uphill one. Okay. We're now affecting more than one organ. So let's talk about MODS for a second. Multiple organ dysfunction syndrome, when progressive impairment of two or more organ systems resulting from uncontrolled inflammatory response to severe illness or injury. What is an inflammatory response? What does that mean?
Swelling.
Swelling, right? Okay, because we have a buildup of these cells in that area, so we start to swell. That's normal. I will tell you, multiple organ dysfunction syndrome is the major cause of death following sepsis, trauma, and burn injuries. It's pretty scary. MODS occurs in two different stages, okay? We have a primary MODS. Organ damage results from a specific cause resulting from episode of shock, trauma, or surgery. Secondary MODS. Next time there is an insult to the body, these cells are activated, right? Because they know our cells have memory, especially inflammatory cells. They see that, okay, something's happening again. I got to kick it into high gear. The problem is they produce an exaggerated inflammatory response, and they essentially attack themselves. They attack your own body. That's another thing. Again, when we talk about COVID, another thing that was happening with patients is their organs were failing. They were going into MODS because their body was having such an inflammatory response to it that it was essentially attacking itself. As a result of inflammatory mediators, a massive immune, inflammatory, and coagulation response develops. Kind of makes sense. Did anybody hear, like during COVID, that some patients were developing blood clots? It's due to this. Their body was trying to fight something and didn't know what it was fighting. So the body's natural reaction was, hey, everybody do their job. Let's clot, let's swell, then let's attack anything that we don't know. The problem is they were attacking themselves. MODS takes a little bit of time. It doesn't just happen instantly. It takes a specific amount of time. And this next slide shows us the time we're looking at. So 24 hours after resuscitation for multiple organ dysfunction. Low-grade fever, we're tachycardic, altered mental status. So if I say tachycardic, what stage of shock do you think we're in?
Compensated.
We're compensating, right? Altered mental status, maybe to fluid loss, dehydration. Within 24 to 72 hours, our pulmonary function begins to fail. Sounds familiar. People with COVID, they were putting them on vents, right? Within 7 to 10 days, our liver fails. Our intestinal region fails. Our kidneys begin to shut down. Within 14 to 21 days, our renal system is now shutting down. Our GI system, our immune system, we're losing everything at this point, right? After 21 days, our blood system begins to fail. Our body is turning on us. Our heart starts to shut down. Our brain starts to shut down due to infection, which eventually leads to death. It's a scary thing when you talk about multiple organ failure, multiple organ dysfunction. All right, let's take a 15-minute break. We'll come back. We'll probably only go till about 8:30, and then we'll be done for the night. So take 15 minutes, and then we'll come back and talk a little bit more. All right, let's bring it back. All right, so our body, when we have certain diseases or certain injuries or certain invasions, right? We have self-defense mechanisms. That's how our body works. We develop what's called antibodies. And now some of these infectious agents, such as bacteria, viruses, fungi, parasites, and what's called prions, are things that are most likely dealt with, or that we may run into when dealing with our immune system and how our body reacts to them. So bacteria, a single cell organism. So that means that it's prokaryotic, right? Remember, we have eukaryotic and prokaryotic. They can reproduce independently, need a host to supply food and other support. So they cannot live on their own. They have to be able to attach to something. Can be cultured and identified in hospital labs, right? Where they put them on the little piece of glass. They take a magnifying glass, they look at them. Oh yeah, there we go. There's a bacteria. Categorized according to appearance after they stain with dyes, what's referred to as a gram stain. Now, since they lack a nucleus, again, they're prokaryotic, they reproduce independently, need a host. What that means for us is inside of our body, they would have to bind to something to stay alive. A good example of this would be if you guys have ever heard of C. diff, or Clostridium difficile is the correct term for C. diff. How many of you have ever transported a patient with C. diff? Don't lie. Yeah, that was a very slow reaction, right? We've all done it. It's fine. Where do we primarily see patients with C. diff?
Nursing home.
Nursing homes.
Nursing. Let's broaden that out a little bit. Healthcare facilities, right? Why do we see them? Even prisons? What causes them to develop C. diff? It's actually inflammation of the GI tract, okay, due to constant and prolonged antibiotic use. Antibiotics causes diarrhea, right? Well, constantly using that creates irritation and creates inflammation. So we then develop this bacteria in our GI tract called C. diff. The problem with C. diff is we also have to take precautions with it because it can be transmitted from person to person. Usually categorized, you'll usually tell based on prolonged antibiotic use, and it has a very distinct, almost sour smell to it, as well as any feces would be like yellowish greenish discharge almost. Bacteria cause many infections. It's something we're used to dealing with. Antibiotics kill or stop the growth of bacteria. The problem again is prolonged antibiotic use can actually hurt us more than anything. Many bacteria release poisonous chemicals or toxins within our bloodstream. And it's up to our body to create these antibodies to essentially target those toxins. Now, we can get a response to a certain toxin, or we can get a generic response to any toxins. That's the difference between immune system and inflammatory response, okay? And then septicemia, obviously being the spread of toxins through our bloodstream. So we start to become septic. Our blood starts to become bad, if you want to put it in simple terms. Then we have viruses. Cause most infections, smaller than bacteria, cannot grow without the assistance of another organism. So a virus in the air is nothing besides what it is. It cannot grow. It has to take over a host. It has to infect a host. Think of the viruses we know about. Think of COVID right now, right? In the air, it's nothing, but it can infect us still. And then it uses our body. It replicates itself. Viruses must invade the host that they infect, right? They have no cellular structure beside what surrounds the genetic material. So they do have like DNA, but no real structure to the cell. Once they decide that they're going to take over a host or they're going to take over a cell, they replicate. They copy themselves. They produce more of themselves. And then they destroy that cell that they took over. Viruses will usually develop a coating, which is actually called an envelope. Think of a virus as a letter inside this little envelope. which will allow the virus to essentially resist destruction by the immune system. Anytime we have some sort of what's called an antigen is something that comes into our body that is unfamiliar to us, right? Our body then has an immune response or it has an inflammatory response. Well, in the case of viruses, we have an immune system response, right? Because our body tries to figure out, the first thing it does when it sees a virus is tries to figure out what it is. It kind of stands back from a distance, it's not sure what it is, doesn't know how to fight it, it studies it. So the next time it comes around, it knows exactly what its weakness is. That's how our immune system works. Once the virus has replicated itself, it'll destroy the host cell. In many cases, a virus can last for months or even years within a cell. That doesn't mean that it's consistently growing because we treat it, but it's still there. Symptoms may not readily appear since it is hidden within the host cell. Again, I know I keep talking about COVID, but it's something that we're all familiar with because it's so new to us. People with COVID weren't developing symptoms right away. It took a little while for this virus to inhabit the cells and for it to really grow and for it to really fester. And even after people, think of your 10-day 10-day waiting period. If you contracted COVID, you were waiting for 10 days. They said you could return to work after that, but you could still test positive for months up to that point, right? And we even developed antibodies to fight the virus up to that point. Another example would be chickenpox. Chickenpox is one of the things that, as a child, it was one of the things we feared, it was one of the things we're vaccinated for, but it stayed in our system for a very long period of time. And it actually came back later in life for us adults as shingles. Some viruses can actually alter the host cell, right? So they can take over and change the host cell. If I have a cell and it alters and it mutates, what disease does that then become? We said it early on in this slide. Becomes cancer when you start to mutate the cell like that. A good example, HIV. HIV causes AIDS, which attacks cells of the immune system, right? It destroys your ability to ward off infections. Since viruses have to transfer from cell to cell, the body generally will try to catch them when they're outside of a cell looking for another one, and that's when it destroys the virus. On another note, I was literally just reading on Facebook, I think KCCI posted it, that the second patient in history had somehow cured themselves of AIDS or HIV. They're not sure how, and they didn't have any treatment for it. Their body just naturally fought it off. Something that I'll read after tonight's class because it's kind of interesting. We also have fungi, such as yeasts and molds, more like plants than animals, rarely cause human disease other than minor skin infections. What are some things we can think of that are fungi in terms of skin infections with humans?
Ringworm.
Okay, what else? It's really common with athletes.
Athlete's foot.
Athlete's foot, absolutely. That's still potentially a yeast infection, right? The problem is patients with immune system disorders such as HIV patients, or even patients with organ transplants, because remember, once you receive an organ transplant, your immune system isn't as strong as it once was. They are more prone to developing some type of fungal disease for some reason. I'm not sure why, more than healthy people. We have parasites. This is more like your ringworm, okay? So they range in size, anywhere from a protozoa, so small, microscopic, all the way up to large intestinal worms, such as a tapeworm. Tend to be more common in developing nations than the US. Why would that be?
Poor water sanitation.
Poor sanitation in general, almost, right? But yeah, absolutely, poor water sanitation. And then we have prions, which differ a little bit from viruses. They're smaller, made entirely of protein, and they don't function the same way, right? They're most recently recognized classification of infectious disease. We're still kind of studying them. We're still not 100% sure of how they work, how they act. They were initially thought to be slow acting, So it took years. But then they realized that wasn't the case. It was just them essentially being dormant, and then just non-reactive at all. So it wasn't that they were essentially waiting. It was just that they weren't reactive. So our body, in terms of these potential infections, has three lines of defense. We have anatomic barriers, we have inflammatory responses, such as swelling, and we have immune responses. So before an infectious agent can attack the body, it has to get past that natural barrier. What is our natural barrier to any sort of infectious agent?
Skin.
Skin, absolutely it is. Believe it or not, the skin also provides a chemical defense against infection. How do you think that is? What chemical could our skin possibly fight infection with?
Isn't it peroxide?
Sweat. Our body emits sweat, right? Who's ever like been exercising and gotten sweat in your eye? What happened? It burns, right? Sweat actually contains fatty and lactic acids, which generally attack bacteria and fungi. You also got to think the infectious agent or the invader can also be coughed out, it can be sneezed out, it can be flushed out of our urinary tract, or eliminated from our GI tract through vomiting or diarrhea. This is our body's natural way. I mean, what happens if I told you to go in your kitchen right now, open a jar of pepper, and take a whiff of it? What would you do? What's your body's natural reaction to that?
Sneeze.
Yeah, because it's not something it is normally used to seeing. So it's not because it smells funny or something like that. It's because your body says, whoa, I'm not sure what this is. I'm going to try to get rid of it. So it sneezes, okay? Same thing with pollen. When we talk about anatomic defenses such as skin, they're external. They're non-specific. They don't target a certain infectious disease. It's just a wall, a broad spectrum of defense. Now, it can also somewhat protect against foreign invaders, but the problem is our skin is pretty pliable. So as far as anything that can puncture, we're kind of limited in that aspect. Once it gets past the skin, though, once it does puncture it, it begins to attack cells. It begins to attack our tissues. And then other lines of defense that are triggered, such as your inflammatory response and your immune response. So this graph kind of shows our three different lines of defense, such as anatomic, inflammatory, and immune response, and how they really act. So anatomic barriers, external, such as skin, non-specific. It doesn't target a certain infectious agent. It's just a broad wall. Inflammatory response, which is an internal response, right? Non-specific, again, it doesn't look for a certain antigen. And then immune response. Now, an immune response is different. We develop an immunity to a certain antigen, right? For some reason, I am immune to poison ivy. I can lay down and roll all around poison ivy and it does nothing to me. That's because my body somehow has immunity to it. It's something that's built up over time. Now, does that mean I'm immune to other things? No, it's specifically to poison ivy. So how these responses kick in, other than our anatomic, our inflammatory response is fast. It kicks in almost immediately, right? Think of allergies. We become congested almost immediately. 5 minutes after walking outside, if there's pollen in the air, I'm sneezing. Non-specific, it doesn't remember any allergens either because it doesn't target any of them. As opposed to an immune response, which is a lot slower, and it targets certain antigens. In my case, poison ivy doesn't essentially inhibit an immune response because it has a memory to it. And it will probably be like that for a long time. Now, something else, maybe, I don't know, like a bee sting. If I was allergic to it, that's when my immune response would kick in at that point. So that immune response detects antigens as foreign. substances that we don't know about, our body isn't used to seeing. It produces antibodies. Remember, our body produces antibodies, and antigen is foreign. Antibodies are domestic, antigens are foreign. So we produce antibodies that combine with these antigens to essentially cling on to them and destroy them. But we can develop an immunity to certain things over a period of time. One of the things they talked about with COVID was herd immunity, if you've heard that. And it was basically, hey, if we expose enough people to it, we will essentially develop an immunity to it that will prevent us from becoming seriously ill or seriously sick. You can also get a natural immunity, which in my case is what I have with poison ivy. It just came naturally. I didn't take a vaccine. I didn't take any certain medication. It was just natural within my body. Now, there are certain immunities, such as an acquired immunity, which could potentially be like a vaccine. They consider that like a passive acquired immunity. Or there's an active acquired immunity. So once you develop, in the case of COVID, once somebody developed COVID, they were generally immune to it for 3 to 4 months afterwards because they built up antibodies. Another word for antibodies, if you ever hear immunoglobulins, they're referring to antibodies, right? The things we use to fight antigens or foreign substances coming into the body. There's 2 different types of responses. That primary response, remember, like I said, an antigen comes into the body, the cells kind of don't know what to do. The antibodies aren't sure what to do. Their job is to fight off infection, but they don't know if this is foreign or not. So they just kind of sit there and watch it and see what it does. But the second time it comes back, they say, okay, listen, we've watched him. We know how he acts. We know what he does. We're taking him down. We know how to function. We know how to take him out. That's how our body works. The primary, they observe and they study. The secondary is when they attack. We also have what's called lymphocytes. Lymphocytes, lymph system. Have you ever noticed if you get really sick or if you have a cold or something like that, your lymph nodes in your neck swell up? They're responsible for recognizing foreign antigens. They produce the antibodies that fight those antigens, and they're responsible for developing memory. We have what's called B lymphocytes. B lymphocytes don't attack the antigens directly. They produce something to do it, okay? As opposed to T lymphocytes, which don't produce antibodies, they just attack. The lymphocytes themselves will go after whatever antigen it is. Now, these lymphocytes are circulated in our bloodstream through our lymph system. You got to think, our lymph system filters blood, right? So they circulate in our blood looking for any intruders, essentially. So how this immune response kicks in, how this all comes about, is we have to have an antigen. We have to have some foreign body or some foreign chemical coming into our body that we're not sure of. Now, not every antigen that comes into our body creates an immune response, such as pepper. If you were to sniff pepper, the body isn't going to create antibodies just for pepper, is what I'm saying, because it's not a threat to it. There has to be a sufficient foreignness, a sufficient size, sufficient complexity with the cells, and present in sufficient amounts. Our body can self-distinguish between self and non-self or foreign antigens. So those are our criteria as far as that we have to meet for our body to kick in the immune response. We do have some antigens within our body, and they're called HLA, which also stands for histocompatibility locus antigens. The body recognizes those as self, meaning it won't attack them. These are present on basically almost cells of the body, on the outside of the cells, so they don't trigger an immune response. And when we look at that like major histocompatibility complex, that's what's called the chief genetic source of HLA antigens. So that's really what gets what these HLA antigens are driven from. So if you hear of a self-antigen, think HLA. All right, we're going to talk about blood real quick, and then we'll call it a night. So blood type A carries only A antigens. Blood type B only carries B antigens. AB carries both, hence why it's the universal recipient. And blood type O carries neither. So it is a universal donor, so it can be given to anybody. There's a certain reason that in the hospital, before they do a blood transfusion, we have to cross and type blood types, right? We have to cross and match because they have to make sure that they're giving the right type of blood to the right person. If not, let's just use this for an example. Let me call on somebody. I've been waiting to do this. Mr. Elliott, if I was to give somebody that carries blood type A, if I was to give them blood type B, what would happen? Well, that didn't work. Anybody else?
Major immune response.
Major immune response. Absolutely. Our body would see it as a threat because it's not used to it. And then our body would then what? Essentially fight our own blood, right? Because it's circulating. Now, let's look at this little chart here, okay? Blood type B is anti-A. Can't take blood type A because, again, we get that immune response. Blood type A is anti-B. It can't get a B-type blood because we'll get immune response. There is a reason we do what we do. When we talk about flight, which type of blood do you think flight carries? They don't have time to cross and check and all that, right? So what are they carrying?
O negative.
Yeah, type O, right? Because O is the universal donor. And then this chart actually shows our different types of blood, our reactions with serum of recipients.
What is the corrective action if somebody's given the wrong blood type?
They'll generally treat them with antibiotics pretty quickly. Usually high strength, such as like vancomycin, is a really potent antibiotics. That's generally what they'll do, and then they'll actually give them the right type and let the body fight it off. Good question. All right, that's where I'm going to end it for the night. We went 2.5 hours of our allotted 3. We got really far. We've actually only got about 70 slides to finish up next week. And then we'll do a little review at the end of that as well. I love talking about this stuff. If you guys noticed, I was a little more enthusiastic. Do you guys have any questions about this or have any input or maybe some patients you've seen in regards to some stuff we've talked about, maybe types of shock, maybe, whether it be allergic reaction, maybe it be maybe some type of immune response, anything?
Not necessarily. Well, I wasn't an EMT yet, but I worked in a care facility where a lady with MS had a catheter and she would have septic shock all the time.
Why is that, you think?
UTI.
Yeah. And that's one of the things as a provider, especially if you go to a nursing home and they're like, this patient's presenting with an altered mental status, we're not sure what's going on, and you notice they have a catheter in, your mind automatically starts floating UTI, right? Again, being a paramedic is not about the skills. It's about our assessment. It's about how we can really look at what's going on with our patients. Anybody else have anything or any questions for the good of the association here? It could be clinical, it could be field, it could be anything.
Rudy, how long do we have to put in patients into FISDAP after our shift?
48 hours.
Beautiful.
After that, it locks, and then you have to email me, and I have to scold you.
Is it a semi-scolding, or is it like full blast hardcore?
I really don't scold you. It's fine.
Okay.
Any other questions or anything I can answer for you guys? All right, if there's nothing else, I'll go ahead and stop the recording. I appreciate you guys' time tonight. I know that